Hello, good morning, friends. I am Dr. Anupam Agarwal. I welcome you all to our digital platform, DocisLive.com. Friends, from today we are starting our second series of 12 webinars with Dr. YK Amdekar. There was an overwhelming response to our first series and on popular demand by doctors from all across India that we are starting this second series. This educational initiative is brought to you by Clinics India through our digital platform, DocisLive.com. And also for your information, GP Clinics is another flagship journal published by Clinics India and is being published every month for last 13 years. For your information, friends, the recordings of all the previous webinars are there on our website, gpclinics.in, and on our YouTube channel, DocisLive.com. Also, the summary of all the webinars is published in GP Clinics print edition every month. Today's subject is approach to joint pains and swelling. Friends, you must have noticed that in the first series, the focus has been on symptoms. Now in this second series, the focus would be on physical findings. Dr. YK Amdekar has been kind enough to agree to be the speaker in this second series also, despite his very busy schedule. For those who are joining new, Dr. Amdekar is a practicing pediatrician for last 50 years. He has been the faculty to Grand Medical College, JJ Group of Hospitals, and Institute of Child Health, Mumbai. He has been the past president of IAP as well. So with this brief introduction, over to you, sir.
Thank you, Dr. Anupam, and good morning, friends. I think in this new series, we are going to take symptoms and signs which are not regularly every day seen in your practice, but certainly you do see them almost every week or 2 weeks, sometime or another. And we thought, having covered almost 12 common symptoms that are seen in practice in the last series, we thought that we would go ahead now with something that may be less common, but certainly not uncommon or rare. And today we are going to discuss about the approach to joint pain and swelling. Can I have the next slide, please? Now, as usual, we will discuss the basics first and then get on to a clinical approach and then the case-related discussion. We all know that arthritis, that is typically an articular disease, will almost look similar to a periarticular disease, which is a disease affecting tissues around the joint, but not the joint. Now, typical articular problem has a painful and restriction movements in all directions during active and passive movements. So when I have a knee joint arthritis, I get pain right from the beginning of movement to the end of the movement, and also during active and passive movements. But a periarticular disease is a bit different. It has also a painful restriction of movements, but only in one direction or often at the end of the movement. So if I have a periarticular knee disease, then I allow the movement to begin with, but maybe at the far end, or to begin with, but not at the end. So the restriction of movement and pain is restricted to not throughout the movement. And most important is, while active movement is painful, the passive movement is not painful. What I mean is, when you ask the patient to move his knee, and he would say, oh, he has a pain and restriction of movements both in articular and periarticular disease. But when you move the knee of a patient, and if he does not get pain during those passive movements, then you know that it's not articular disease, but it's a periarticular disease. I hope I'm very clear. So every time you examine the knee joint, for example, you look at whether you moving the joint is not so painful as against the patient moving the joint. And also whether the pain is throughout the movement or only restricted to some part in some direction. But there is something more about it. So if you see the swelling beyond the joint, in the joint, then we need to observe whether it is beyond the joint line. And what is joint line? It is a joint line which is at the extreme medial and lateral aspect of the end of the joint. So you have a knee joint, you have a medial end of the knee joint and a lateral end of the knee joint. If the swelling of the joint or around the joint has gone beyond the joint line, that means beyond the end, medial and lateral of the joint, then I know that it's a periarticular affection. And I think this is very, very clinically important. And therefore, please make a note. You look at active and passive movements causing pain or no pain. And you also look at whether the swelling around the joint has gone beyond the joint line, which is typically a joint line is restricted by the medial and lateral end of the joint. And if it goes beyond, the swelling goes beyond this line, then you know it's a periarticular. I think this is a very crux of the problem of a typical joint science and the clinical impression. Well, of course, if you have a swelling which has a patellar tap, that means you tap the center of the swelling and it gives you a feeling that there is something displacing beneath that. That means there is a synovial fluid collection, and obviously it's an arthritis. But not every arthritis has a synovial fluid collection. And I'm sure we all know by now that arthralgia is pain, whereas arthritis is pain and swelling both. So when you have a person complaining of pain in the joint but without swelling, it will be called as arthralgia. And when there is the pain as well as swelling, then it will be called arthritis. So swelling is the hallmark of arthritis and often accompanied with pain. I think with this clear manifestation of the basics, let me have the next slide, please. Now, this is for your interaction as usual. The joint disease may be caused by musculoskeletal disorders, vasculitis, connective tissue diseases, or all of the above. Your time starts now. Very good. I think what a perfect start to this new series. I think almost all of you have said that a joint disease may be either due to musculoskeletal disorders, maybe due to vasculitis, or of course, maybe connective tissue disorders. Friends, when it's a musculoskeletal disorder, it's the bone or the muscles around the joint. Vasculitis is the blood supply to the joint, and connective tissue disorders are the subcutaneous tissue around the joint. So, any of these sites could be presenting as a joint disease, and therefore you have some more clinical approach to discuss about to see whether the etiology of a joint disorder lies in musculoskeletal connective tissue or a vasculitic problem. Good. But I think we are all aware that the pathology could lie anywhere, ultimately leading to an arthritis or a joint disease. Can I have the next slide, please? Now, the next slide just summarizes the causes in general that we like to keep in mind when we start discussing clinical case scenarios. Inflammation is the most common cause. And we all know by now that inflammation is clinically seen by a swelling, by redness, warmth, and also tenderness or pain. And the common causes are septic arthritis. You might have other infections causing arthritis, like even viral infection can cause arthritis, fungal infection, parasitic infection, and of course TB as well. But besides this infection, the other inflammatory disorders, the common one is a reactive arthritis, which is a reaction to some viral infection which disappears by itself but leaves behind some evidence of arthritis. It's called a reactive arthritis. Transient synovitis presents almost as arthritis because the synovium is a part of joint, and transient synovitis is pretty common in a very minute hidden trauma, which patients often may not even know, especially sports injuries or somebody doing exercise in gymnasium, etc., might have a very mild trauma. And classically, a hip joint synovitis is very difficult to make out because the hip joint is not accessible for your simple clinical examination. Trauma, of course, of any kind, acute rheumatic fever. What is the difference between reactive arthritis and acute rheumatic fever? Largely, acute rheumatic fever is also a reaction to a streptococcal throat infection. But the difference is typical acute rheumatic fever occurs 2 to 3 weeks after the disappearance of streptococcal throat infection, while the reactive arthritis follows within 2 3 days of not only streptococcal but varieties of infections. And other differences, reactive arthritis is often polyarthritis but static, whereas a rheumatic fever is often polyarthritis but migratory. That means one joint gets affected, after a day or two, the other joint starts getting affected. By the time the third joint gets affected, the first joint is already recovered. That is called a migratory type of reaction, and that is seen in rheumatic fever. But friends, migratory arthritis may also be seen in other disorders. But typically, a reactive arthritis is a polyarthritis, non-migratory, occurring within 2 3 days of an infection and often involves big and small joints, whereas a rheumatic fever almost always is restricted to big joints and not small joints. Then vasculitis, like a henoch-Schönlein purpura, for example, is a typical vasculitic arthritis, where there is also some other evidence of vasculitis in the body, typically thrombocytopenic purpura on the skin, or sometimes even an abdominal pain causing a severe intestinal colic. But we also have many types of chronic arthritis, especially in older children and adults, and that includes the juvenile idiopathic arthritis, which earlier was called as the rheumatoid arthritis. Now that term is given up. Then, of course, the systemic lupus. There could be any other forms of immunological disorders like a dermatomyositis, the juvenile dermatomyositis, and various types of spondylodystrophy or arthropathies, where a back and neck vertebral column is also involved, and many of them have also other immune manifestations like the inflammatory bowel disease. These are pretty common. The spondyloarthropathy and inflammatory bowel disease are pretty common in adults as well as older children, and they also present with arthritis. The point is, some of these chronic arthritis could have multiple parts of the body involved, but the onset may be only with arthritis. And in a typical juvenile dermatomyositis, the skin is involved. In spondyloarthropathy, the back is involved. And therefore, to that extent, you have onset with arthritis, but other manifestation may come little later. But inflammatory arthritis is the most common cause. Of course, don't forget hematological disorders like hemophilia, typically coming with bigger joint involvement during even a minor trauma. a leukemia, which very closely mimics arthritis, occasionally scurvy, which is certainly getting very, very uncommon and rare in our population. Degenerative arthritis is the most common arthritis you all must be seeing in old age. Osteoarthritis, the most common cause, and even the hypermobility syndrome, the mechanical cause of arthritis, often comes with pain but not swelling. And these are the children who were earlier referred to as growing pains, where whole day they run about, jump about, they don't get tired, but in the night when they rest, their bones and muscles ache, and then they like to be massaged all the time to relieve pain. Hypermobility is simple to diagnose because that's one type of pain which is relieved by massage, whereas all other arthritis, the pain is worsened by any pressure or any movements. Rarely, metabolic causes can also come up, and in adults, in particularly, gout is one cause of arthritis. There are many other metabolic disorders like Gaucher's disease, sarcoidosis, amyloidosis, but not common, certainly rare. And finally, there could be a genetic arthropathies which stimulate arthritis. They are, of course, seen very early in childhood, like chondrodystrophies and Marfan syndrome and many others. And we will not go much into those details because they are not very common. But if a young child or an infant or a toddler comes with multiple joint swelling, you need to keep in mind whether it could be a genetic disorder. Having given all this, let's see the next slide, please. Now, what's the clinical approach really? Whenever you see an arthritis, the first point is it arthritis? I've already discussed how to differentiate articular from a periarticular disease. Once you are sure that it is arthritis, the next step is it inflammatory arthritis or a non-inflammatory arthritis? And it's easy because inflammatory arthritis has pain, tenderness, is far more common. In non-inflammatory arthritis, usually there is no pain and no tenderness. So it's easy. Once you know it's an inflammatory disorder, we look at whether there is a morning stiffness and the patient gets better as the day goes on. Is classically the onset of an inflammatory arthritis, whereas the typical degenerative or mechanical arthropathies are worst in the evening after exertion. So once you know it's arthritis, whether it's inflammatory or non-inflammatory, then you try to differentiate further by whether it is inflammatory or degenerative, mechanical, and that is a big difference. If it's inflammatory, then of course consider common infection as well as non-infective conditions like we discussed about rheumatological conditions and also malignancy. Now, if there is a night pain, which means that the patient wakes up halfway through sleep with a severe joint pain, then this indicates complications occurring in arthritis and is referred to as an erosive arthritis. That means there is an erosion in the joint occurring, destruction in the joint occurring, and therefore anyone who wakes up with pain in the night, wherever the pain may be, abdominal pain, headache, or of course joint, we are going to consider it as something sinister and something very much pathological. Of course, like everywhere, we look at onset, duration, progress, onset of an acute illness, often septic arthritis or immune-mediated reactive arthritis, traumatic arthritis, or it could be slowly worsening, as in the case of rheumatoid arthritis, or now known as a juvenile idiopathic arthritis, and many other immune arthritis. The duration, of course, long duration, a chronic problem, degenerative disorders go on and on for years, progress, often inflammatory, non-infective inflammatory joint problems like juvenile idiopathic arthritis, go on worsening over time if not treated, whereas degenerative disorders also keep on worsening over time. Number of joints involved are very important, and also big or small joint, and whether it's a migratory or a variable pattern. And of course, we look at other symptoms that may be accompanying joints, right? Having seen the clinical approach, let's kind of put all that into a clinical case discussion. And here is the first case. Can I have the next slide, please? This is a young adult. I have chosen most of the patients as young adults or senior adults because joint problems are far more common, but no more less common in children as well. But certainly far more common in older children and also adults. So this is a young adult presented with pain in the left knee joint of an acute onset and difficulty in walking for 2 days. There is no fever at all. Physical examination, it has an antalgic gait. Antalgic gait means it's a painful gait involving the left knee. There is no swelling, no tenderness, no restriction of movements. Otherwise, the patient is normal. Take a note, just pain and difficulty in walking. That's it. Your options are it's a functional pain, it's arthralgia, which could be some evolving disease. It could be any of the above, or it could be none of the above. Your time starts now. Well, majority of you said it's a functional pain, while one third of you have said it could be an arthralgia, which exactly means only pain without swelling, and another one fourth feel that it could be any of the above. Can I have the slide, please, back? Now, it is rare to have a young, healthy adult to come out with sudden functional pain. Remember, a functional disorder of any kind, typical functional abdominal pain, functional headache, functional joint pain, are all simply referred to as a pain of convenience. That means they come at a convenient time. They don't disturb your routine at all. And therefore, functional pain is unusual in a young adult of an acute onset of 2 days. He would complain of longer duration and he would say, I can run while playing, but it certainly hurts while walking. That kind of a, so any functional disorder, I call it simply as a pain of convenience. Okay, it comes at convenient time. So that is unlikely. Yes, it is arthralgia, but I wanted to bring a notice to you that this arthralgia may disappear by itself if it was a mild hidden trauma that this young adult even did not know, or it could be a beginning of an evolving disease. Often, a swelling may follow the pain. And remember that when somebody comes with pain, tell him to report to you back if the swelling starts coming over next other day or two. It could be an evolving disease of any kind. And many times, those joints which present as swelling may start with pain at the onset, but within a day or two, you see the swelling as well. You know, then when you bump the head, immediately there is the pain, but the swelling comes after a few hours. And therefore, a typical head injury, a severe head injury, the patient is neurologically all right for a few hours and thereafter he deteriorates. So the swelling comes a little later, and that is the importance of knowing arthralgia, and don't dispose the patient of giving him an impression that nothing will happen. Can I have the next slide, please? Now, the next case is a middle-aged adult who presented with very acute onset of severe pain and swelling of just one big toe. Just one big toe is involved, and there is a swelling and pain. for 2 days. Physical examination showed signs of acute inflammation of the toe. Okay, other joints and systems are normal. Now take a note of this here. A toe swelling is very difficult to know whether it's any joint involvement or the entire toe involvement, but the whole toe looks, after all, it's a small area, right? Now, with all those limitations, I want you to pick up one of the four options. Your options are: he developed a fracture, it's an acute bacterial cellulitis, it's an insect bite, or it could be none of the above. Your time starts now. Very good. Uh, Almost good, one third or more are in favor of bacterial cellulitis, fracture, or none of the above. Okay. Now let's see the slide back. Now, if you look at carefully, first thing is there is no fever at all. Make a note that acute infection in a healthy child almost always starts with fever, and along with or a day or two later comes the localizing signs. I'll repeat that. An acute infection in a healthy person starts with fever, and if it's a bacterial infection, it localizes within a day or two. But this person started without fever, and the onset was straight with pain and swelling. So the swelling was acute onset and pain. Can we have the slide back? Yes. And therefore, acute bacterial cellulitis is out. Could it be a fracture or could it be an insect bite? One of the two. Now, to get a fracture of the bone in a middle-aged adult, it's very nearly impossible that he has totally not taken note of his injury. Fracture is not a hidden injury, especially in a fit adult. If it's somebody osteoporotic, yes, or somebody who has severe rickets, yes, he could easily, with a minor trauma, get a fracture. But a middle-aged adult is uncommon to miss his injury, which has caused fracture. Therefore, it could be a local injury without a fracture, and that could as well be trauma. Yes, you are right to that extent, but unlikely a fracture or simply an insect bite. I was just going to bring out a point in this case that what looks like a swelling over a very small joint is very difficult to note whether it's a joint involvement, a bone involvement, or whether it's really a totally outside the bone and outside the joint in the subcutaneous tissue itself. And this is important. For example, a typical sickle cell disease, which causes obstruction to the capillaries and therefore almost a small part of the periphery of the toes do not get a blood supply, and therefore they have a swelling coming out of an obstruction to the vasculature, and they present with a hand-foot swelling. It may be unilateral or it may be bilateral or often multiple, and to that extent, it is difficult to make out whether in a small joint it's a joint or something around the joint. And I'm sure, just to make a point more elaborate, you may be surprised that a wrist joint, what we call often a simple wrist joint, is involving 20 joints. At the wrist, you have 20 joints. Okay, beyond the wrist. from the wrist to the toe, to the fingers. You have 20 joints in the hand. And what are these 20 joints? Besides radius and ulnar, you have 10 of them, the smaller joints, and then the phalangeal joints. Okay. So you have so many joints in the hand, 20 joints, and between each of these bones, there are joints like you have trapezius, trapezium, uh, hamate, cunate, pisiform, multiple small bones. Okay, carpal bones, 8 carpal bones, radius ulnar, 2, 10, and you have a 5 phalanx and also smaller ones, makes it 20 joints. And if you have a swelling over the hand, it's nearly impossible to find out, and you have to be very careful. Sometimes you might look at an imaging to find out whether the bone is involved or not. Luckily, these joints don't move much independently, and therefore, even if there is a big toe fracture, you need not really. You can just put a very tight bandage, and that's enough. That fracture will also heal. This was just to bring out a point that small joint swellings are not so easy to kind of clinically go further on that, and you have to be very careful. Let's see the third case. Next case, please. Now, this is a young adult who presented with high fever and pain in the left knee, followed next day by swelling and redness. Look at the story. On day 1, fever and pain in the left knee, but no swelling. On the next day, develop swelling and redness. On examination, you have signs of severe inflammation, and other joints and systems are normal. Your choice is between acute bacterial arthritis, what's called as septic arthritis, acute viral arthritis, onset of rheumatoid arthritis, or a traumatic arthritis. Your time starts now. Excellent. Can I have the slide back? Now, most of you have said rightly acute bacterial arthritis, but few of you have thought it could as well be an acute viral arthritis. Yes, good thought. And occasional persons have thought it could be even rheumatoid arthritis, traumatic, etc. Let's see minutely the difference between all this. Almost always, a viral arthritis manifestations are of polyarthritis rather than monoarthritis. So that is one point against viral arthritis. Could it be an onset of rheumatoid arthritis? For example, I'm using the word rheumatoid only because that is very prevalent, especially when I was trained 60 years ago, and quite a few of you have been trained 10, 20, 30, 40 years ago. But today we call it as idiopathic arthritis, and often starts during childhood, below 18 years of age, and it's also referred to as, therefore, a juvenile idiopathic arthritis, JIA. But let's retain the term for our discussion for easy understanding. Now, rheumatoid arthritis may rarely be also monoarthritis to start with, but often does not have high fever and acute onset. Okay. In fact, the typical rheumatoid arthritis starts with arthritis, but often without fever. And one type of rheumatoid arthritis, which starts with fever, often does not have arthritis at that time, and that is known as a systemic onset of rheumatoid arthritis, where the fever goes on for a few days before even an arthritis comes in. I hope I am clear. A typical rheumatoid arthritis does not present with fever, whereas a high fever at the onset of rheumatoid arthritis is almost always without arthritis to begin with, and after a week or two, arthritis may appear. Therefore, it is not a beginning of a rheumatoid arthritis. A traumatic arthritis is not likely to have fever at the onset, and therefore, this was typically an acute bacterial arthritis or a typical septic arthritis. I must make a mention here of one important thing, that if you have a septic arthritis, then you must refer this patient immediately to an orthopedic surgeon, because he must even get rid of any pus that may be forming already in the joint, and only antibiotic is not an answer. Well, antibiotic may get this patient all right, but at the cost of damage to the joint. And therefore, within quote and quote, unquote, acute bacterial or septic arthritis is a reasonable medical emergency, and an orthopedic surgeon must be involved at the earliest, and he may decide to go in and even kind of aspirate the pus from the joint. And that is very important for you and me, who see this septic arthritis as the onset of the disease. And if you are sure it's a bacterial infection, like in this child, even within 2 days, you would certainly send this child straight away to orthopedic surgeon, right? That is the importance of knowing this kind of a case scenario. Can I have the next slide, please? Now, the next is a young, healthy adult who presented with high fever that lasted for 3 days and got better. And thereafter, 2 days later, came with joint swelling and pain in both the knees and ankles. Take a note, initial fever got better after 3 days, and 2 days later, developed a bilateral knee and ankle joint swelling and pain. On examination, there was a moderate tenderness and moderate restriction of movements on all affected joints. And your probable diagnosis choice is it an acute rheumatic fever with arthritis? Is it acute reactive arthritis? Is it rheumatoid arthritis? Or is none of the above? Your time starts now. Excellent. I expected this response. Okay. This is typically an acute reactive arthritis. Okay. It is unlikely acute rheumatic fever, because a typical acute rheumatic fever is a migratory polyarthritis and comes after 2-3 weeks of whatever infection was preceding. This followed within 2 days, and therefore it is not rheumatic fever. Okay. And it is not also rheumatoid arthritis, because it does not start with high fever and then follows with joint. I told you that a systemic onset of a rheumatoid arthritis starts with fever, and after several days, maybe often a week or two, the joints come up slowly. Okay. So this is typically an acute reactive arthritis and almost always settles down by itself. Can I have the next slide, please? Now, the next one is a middle-aged adult again, who started with very mild pain in small joints for 6 weeks. And then he also had pain in the big joint developing for 4 weeks. So initially 2 weeks, only small joints were involved. Thereafter, even big joints were involved. There was no fever at all. Examination showed symmetrically involved big and small joints with very mild swelling and mild tenderness. In other words, this was a mild form of a polyarticular big and small joints and without fever. Your choice is reactive arthritis, tuberculous polyarthritis, rheumatoid arthritis, or any of the above. Your time starts now. Wonderful. I must congratulate all of you. What a phenomenal response. Yes, I think it's not reactive arthritis simply because, can I have the slide back, please? The story has no fever at all preceding. A reactive arthritis is a reaction to some self limiting fever. And here there was no fever at all. That's why it is not reactive. It's unlikely TB because a tuberculous polyarthritis is rare. Of course, known, but rare. And in that case, it is typically accompanied with a generalized systemic symptoms of tuberculosis like uh, loss of weight, loss of appetite, low grade fever, whatever. And polyarthritis is rare in TB. Both put together, this is not TB arthritis. This is typically a rheumatoid arthritis. And now you have seen that rheumatoid arthritis often comes without fever, with a slow onset, mild swelling, tenderness, not an acute onset of high pain, tenderness, etc. And very classical is a symmetrical involvement of all joints. Okay. And therefore, this was typically a rheumatoid arthritis, right? Let's have a next slide, please. The next case was again a middle aged woman presented with mild fever and migratory pain in few big and small joints for 2 weeks and skin rash on the face for a week. Make a note, fever has been mild and there is a big and small joints involved both for 2 weeks. They are migratory pain. Okay. So it's a pain more than swelling. It's a pain. So there is an arthralgia which is migratory. Big and small joints both are involved. And then after a week of all this, the story continues, but also develops a skin rash over the face. Examination showed no swelling or tenderness of any joint. There was only arthralgia, but there was a rash on the face. Now, your probable diagnosis, you choose between rheumatic fever, serum sickness, which is usually a reaction to a drug, acute reactive arthritis, or a systemic lupus erythematosus, SLE. Your time starts now. Excellent. I think you got the whole story right. Now, take a note. Can I have the slide back? This is the only case where I put up a gender. Okay. So far, I have just said middle-aged adult, young adult. Here I am saying woman. What does it mean? SLE is far more common in women. That's number one. Of course, that doesn't mean that anything happens in a woman is an SLE, but that's beside. Okay. What is peculiar here? The fever is not a very significant symptom. I said in rheumatoid arthritis, often there is no fever at all. But in other immune mediated diseases like rheumatic fever, okay, there is fever as a major sign, or in a reactive arthritis, fever is the onset of the story. Here, mild fever. And second, there is hardly any swelling, but arthralgia. In a typical rheumatoid arthritis, there is a swelling, whereas in many other immunological chronic arthropathies, there may not be swelling but only pain. And here, both big and small joints are involved. But what is important is there is a skin rash. I did not want to put it as a butterfly rash because typical SLE is a butterfly rash on the skin, and it spares the nasolabial folds and looks almost like a butterfly extension over the face, and therefore this is typically an SLE. What is important to pick this up, even at this stage, that SLE is a very dangerous disease, even more dangerous than rheumatoid arthritis often, So even rheumatoid arthritis is a dangerous disease. And if you would have seen this even in the first week, where there is no skin rash, you could have considered SLE. And with the skin rash coming, you should rush this child to a rheumatologist because the management is so complicated and so important for you and me as the general physicians to pick up an early diagnosis in all such cases so that the outcome is very good. Can I have the next slide, please? Now, this is an old man of 60 years. He starts with pain in the big and small joint over the last 2 months, followed by swelling. First, he had only pain, then he has swelling, increasing in severity, restriction of movements, no fever. But on examination, he shows swelling and tenderness and restriction of movements in many joints which are affected. But besides that, he also shows deformities in few joints and wasting of both quadriceps. Now, your probable diagnosis to choose from is this is chronic rheumatoid arthritis, this is osteoarthritis, this is osteodystrophy due to chronic renal disease, or it could be any of the above. Your time starts now. Very good. Can I have the slide back? Now, I got this osteodystrophy due to chronic renal disease only because in chronic renal disorders, especially in adults, you might see a joint involvement. But this happens well after the chronic renal disease has manifested, which means there is edema, there is hypertension, there is renal failure. Many things have already happened. And now such a patient develops a joint problem. It is related to a renal disorder because kidney manages calcium phosphorus metabolism. And when the renal tubules are involved in a chronic renal disease, you also get an osteodystrophy, which looks like an chronic progressive osteoarthritis, but it is not only arthritis, it's entirely the bone is involved, and more important, preceded by a chronic renal disease. So this is out. Now, most of you have opted between rheumatoid arthritis and osteoarthritis, and I wanted you to take a note of physical examination in this child. The story is for 2 months. Okay, that's why some of you thought of rheumatoid arthritis. But what is important is when on physical examination, I already find deformities in few joints and more so wasting of both quadriceps. What do you mean by wasting of quadriceps? This 60-year-old has not been using the knee joint well for a long time. And as he does not flex and extend the knee joint because it's painful and because it's deformed, therefore the muscles moving those joints are wasted. And this case I wanted to bring out specially to tell you that the symptoms may apparently be only 2 months because he's worried more because he has more pain now or more swelling now. But when examination shows deformities of the joints and also wasting of muscles, you know that the disease has been existing for many more months and not just 2 months. And that puts rheumatoid arthritis out of the story and gives you osteoarthritis. Then why did this person not bring out those earlier symptoms to you? One, because you never asked whether he had any other problems in the past. And second is, he often ignores his milder problem. Don't forget that patients often ignore milder problems and come to you only when the problem becomes severe. And this is a classical example of how examination finding deformities on wasting of muscle tells you straight away that he has been suffering for 6 months or a year, and therefore diagnosis osteoarthritis. Can we have the last case? Next case, please. Now, this is a young adult who presented with severe abdominal pain for 4 days. That was followed by pain and swelling of both knees and ankles. There was no fever. Take a note, severe abdominal pain for 4 days, and thereafter pain and swelling of both knees and ankles. Physical examination showed mild tenderness and swelling, soft abdomen, no guarding, no rigidity, but purpuric spots on the skin. Your probable diagnosis rests between serum sickness, SLE, leukemia, or none of the above. Your time starts now. Good. Okay. I think quite a few opted for serum sickness. Of course, few have opted for many other causes as well. Let's have a slide back. Now, take a note of this. This child has severe abdominal pain. Now, remember, in the last series, we discussed pain somewhere, abdominal pain as well as headache. And in that, I had said that though pain is commonly inflammatory, the pain may be vasogenic, that means vascular, or a neurogenic. Now, this child has a soft abdomen. There is no guarding rigidity. Therefore, this is not an inflammatory abdominal pain, and this is likely to be a vascular abdominal pain. In other words, along with such a severe pain and no local sign, it's likely to be a vasculitis. Now, that same vasculitis in the abdomen, which means the vessels supplying in the intestine, also have caused now a purpuric spot. That means the vessels over the skin, and also have caused vasculitic finding in the knees and ankles. And therefore, this is typically what is known as a Henoch-Schönlein purpura. It was good thought on your part to put your bet on SLE, leukemia, serum sickness. They all look alike, but there was a small difference. We saw typical SLE. Yes, typical SLE has joint manifestations more than anything. Skin manifestation of a rash, purpura may also be there, but a typical abdominal pain, rare. And the story is more of a joint rather than just simply that. And the story goes for a little longer time and not an acute onset of a severe abdominal pain. Serum sickness typically present with high fever, arthritis, and a skin rash. Here, fever is lacking, and leukemia often presents not with abdominal pain. Joint involvement comes a little later in leukemia, but the first symptom of leukemia is fever with pallor and purpuric spots, and often with hepatosplenomegaly or a lymphadenopathy. But I'm happy that I have chosen to give you options which can almost be right. And I'm very happy that each option, and you have been thinking of it, though finally it may be little different, but that's a good thought. After all these kind of interactive sessions are meant to sensitize our thinking and not just give one diagnosis, but give a two, three possible diagnosis. And I'm very happy that quite a few made a choice of one or the other. And therefore, let's now end up with small number of discussion on investigation. Can I have the next slide, please? And I think again, one small interaction. Which of the following tests are diagnostic of rheumatoid arthritis? RA factor, ANA, X-ray of joints, or none of the above? Your time starts now. Very good. We are again reasonably divided. Okay. What I wanted to tell you here was that none of these tests, RA factor, ANA, or X-ray of the joints, can make a definitive diagnosis of a rheumatoid arthritis. Okay. RA factor is never to be done in rheumatoid arthritis. Take a note of this statement. RA factor is never to be asked for in a rheumatoid arthritis except an older female adolescent child. I make a note, older female adolescent with polyarticular rheumatoid arthritis, which possibly is only 5% of the entire rheumatoid arthritis, is RA positive. RA positive has no meaning otherwise. ANA positive has no meaning. You might be aware to know that even normal population, 10-20% may have an ANA positive, and merely ANA positive has no value whatsoever. In a typical SLE, not only ANA, but dsDNA is positive. That is diagnostic. X-ray of the joints only tell you how much is the joints affected, destroyed, damaged, and therefore none of them are diagnostic of rheumatoid arthritis. The next slide quickly revises. The next slide, please. Quickly revises the investigation. I'm sure you all know that if it's a septic arthritis, do all CBC, etc. Reactive arthritis, no test. Rheumatic fever, of course, ASLO or an echocardiogram. Transient sinusitis, just ultrasound. Gouty arthritis, of course, serum uric acid. Osteoarthritis, do nothing. Clinical diagnosis, but to assess whether there is already a damage occurring, an imaging like a CT or MRI could be considered. Chronic non-infective inflammatory arthritis have some supportive tests like an ANA, etc., but not diagnostic. And of course, genetic arthropathy may have a genetic test. And the last slide here, before we end up, the last slide is not important. The next slide, please. Management is not important to discuss. All that I would say is that majority of the joint problem need a referral. Acute arthritis, septic referral, chronic arthritis need referral, and a diagnostic dilemma needs referral. Counseling is the important management. Of course, you can use LSH, etc. And last slide just shows you the take-home message. The next slide, please. Recognize potentially damaging acute joint disease. Very important. Early suspicion and timely referral of chronic joint problems are very important. And reactive arthritis and transient synovitis are only diagnosed clinically. And that's the only thing that you and me should treat because both have a good outcome. Thank you very much for this patient hearing. And back to Anupam, we are almost through our time.
So with your permission, sir, can we take few questions?
Yes, I'm sure we can.
So many questions are trickling in. The first one is, what is the significance of arthralgia?
Well, as I had mentioned earlier, that arthralgia may be an onset of an arthritis, or it could be a manifestation of a self-limiting pain, which could be traumatic, mechanical, or immune, and will disappear by itself. And therefore, I think the arthralgia is not to be disposed of as a benign disorder, but you must make an attempt to be sure that it's not going to be an onset of arthralgia. Call the patient back in 2 days. Tell him that take an NSH and then come back if the pain worsens or if a swelling comes. That's the way to go by it.
The next question is how to know the difference between joint disease and periarticular disease.
Yes, I think this is important again for me to make a point that periarticular disease, the passive movements are not painful. You try to move the joint, the patient accepts it. But when he tries to move the joint, he gets pain. That's number one. Second is, if there is a swelling, then if the swelling is beyond the joint line, and a joint line is between the medial and lateral part of the given joint, if the swelling extends beyond the joint, it's a periarticular swelling and not the articular swelling. So keep a note of these two findings and you can easily differentiate between periarticular and articular.
Another question is how to differentiate between inflammatory and non-inflammatory joint disease.
Well, this is far more easy because inflammatory condition has a symptoms or signs of inflammation. And what are those? Pain and tenderness, warmth, swelling, and painful movements. But the point is, if there is a chronic inflammation, if it's a mild degree of inflammation, then you may not have any of these. Then how do you know it's an inflammation or not? In which case, you may have to kind of move the joint more vigorously, or if there is a swelling, then press on the swelling. And then he will say, oh, it hurts a little. That little pain or little tenderness or little restriction of movements is important to pick up that it's inflammatory. But of course, when there is a damaged joint, like an osteoarthritis, he will also have pain or restriction of movement, but that happens in a chronicity. And that's why the difference between acute inflammation and acute non-inflammation is easy, but chronic inflammation and non-inflammation is not so easy. And you have to be very particular about what must be the primary cause of this disease.
So let's take one more question before we close the session.
Yes.
How to differentiate between infective and non-infective inflammatory disease?
So I think that's a very important question. Acute infection is easy to differentiate because acute septic arthritis starts with very high fever and an extremely tender joint, extremely inflamed joint. That is septic arthritis. But if any acute non-infective inflammatory joint starts, then it does not have often very high fever and it does not have often very severe pain. But one more major difference is acute infective septic arthritis is a monoarthritis. Only one joint is involved. Whereas an acute non-infective inflammatory disease has often multiple joints. So multiple joint, not so severe, not so high fever, yes, non-infective, very high fever, and acute inflammation and monoarthritis is a septic arthritis. And I think this should be very easy for us to get. I think we have had 4 questions. I'm sure if there are many more questions come to Dr. Anupam, he would pass on to me and I will put them onto the summary that I'm sure he will publish in the GP clinic. And I feel that should be the end. I hope, friends, you got some idea about this and you are happy about it. Please send your kind of views on this, whether you find even this kind of series on not so common symptoms are also important for you. Thank you very much.
So with this, we are coming close to this session. So thank you, Dr. Amdekar, for this wonderful session. We hope this interactive session would have made learning interesting for attending doctors to help empower their practice. On behalf of Clinics India, DocisLive.com and GP Clinics, I thank all the doctors who have attended this session. Please note the date for the next webinar. It will be on 19th November, Sunday, 11 a.m. The topic would be approach to neck pain and swelling. So thank you once again to all of you. Good day.
Thank you. Good day to all of you.